Welcome back to Season 3. This season we'll be looking at a new aspect of sustainability, the healthcare sector. And so, our season title is A Manifesto for Surgical Health in Africa. I have invited Professor Bruce Bickard to host this season, the first time Earthcast will be hosted by someone other than myself. Bruce will unpack his new book through interviews with African and global experts in the field who helped him write it.
Good afternoon. Welcome to the next session of Earthcast. It's my privilege today to be hosting Nicky Kalafatis and Rupert Pearse. So Nicky Kalafatis is an anaesthetist and intensivist who's currently working in the UK, but she's had a background of working in South Africa for over 25 years. She researched education and fitness for purpose in teaching and training in anesthesia and intensive care. Rupert is a close colleague of mine. Rupert Pearse is a mentor and a colleague. He's based at Queen Mary's University, London. Also an anaesthetist and an intensivist and professor of intensive care in the UK, and has been fundamental to the work that we've all been doing across Africa. So we're going to start today. So we're looking at part 2 of the book, and this is about the inside-out quality surgical care model. And I'm going to start with a little reading from the book, and it's because it introduces Nicky well. The work by Nicky Kalafatis, a South African anesthesiologist, provides an insight into one of the dominant reasons, humaneness, or the quality of compassion or consideration for others. This is best illustrated by what happened the day before the publication of ASOS Obstetrics, which was outcomes for mothers who had caesarean sections in our ASOS study. And that showed the world that women in Africa are 50 times more likely to die following a caesarean section in high-income countries. A news video by Dr. Azza Mashumba, the head of the Division of Pediatrics in Harare, had just gone viral. This was the day before. She's standing in a patient reception area, clearly distressed, with tears streaming down her cheeks as she sums up the futility and despair of working in a dysfunctional, ill-resourced environment. A mother presents. The baby is distressed. I can hear a fetal heart. We come here to main theatre. The fetal heart is dwindling. It's going. We get into theatre. I'm ready to receive the baby, and I'm given a stillbirth. There's just no urgency. We're trying so hard. We're making a plan, coming up with contingency plans. I come to work. I do my very best. But my outputs are stillbirths. My output are disabled babies. Elective lists are not being done. We wait for it to become an emergency. And when it becomes emergency, I'm given a baby with a hypoxic brain injury. This child now has permanent disability. This is not acceptable. Essentially, this was prophetic, a summary of the findings of our study. She concludes with, I'm here because I'm desperate. I've tried, we have tried, but I feel we're not getting heard. We need to move. I'm so sorry, but this is really heartbreaking for me. We are struggling with the work we're doing. We're not helping others. So, we've done all this work, and Nicky, what we've learned is that despite these terrible situations, which Dr. Azza Mashumba summarizes, there's this willingness to try and provide better care. And you touch on this in all your works for your doctors on this concept of collective competency. Can you tell us a bit about that and how it relates to these stories?
Thanks, Bruce. So I think the way this idea kind of developed for me from a humaneness point of view was really looking at, particularly in Africa, where I have obviously my most experience of how people find themselves clinically and emotionally. And I think a lot of the times we are working in really stressful scenarios where we're trying our best for patients and you're wanting to give them better outcomes, better chances. Your heart breaks for what you see because you realize that sometimes, there's only so much that an individual can do. The problem with looking at competence as just an individual is that I think we think that if we can get all our individuals highly trained, highly competent, that that's going to automatically result in collective competence. And that hasn't been shown to be the case. So I think, first of all, I mean, in our research that we looked at, in looking really at non-technical skills for anaesthetists, for specialist anaesthetists, in order for you to be on the pathway, the continuum to being fit for purpose as an anaesthetist, one of the things that we felt that we needed to add in from a South African perspective, and I think is relevant to the rest of Africa, is the concept of humaneness as well as context awareness, which hadn't been included separately in the CanMed's design or framework. So I think particularly in Africa, where we are faced on a daily basis with these heartbreaking stories of difficult situations, especially related to mothers and children, I do think that it is a non-technical skill that without doubt our specialists need to have to be able to do their work properly. Going into that really is, you can't have a single person in the team who's bearing that burden, that tenderness, compassion, sympathetic burden, if you want sustainability of your workforce. I think this type of burden, this emotional burden, actually does need to be carried by the entire team. And that's part of why collective competence is so much stronger than individual competence. It's really, from that point of view, it's not about, it's greater than the self, as I think you mentioned it in your book. And it's certainly, from a collective competence point of view, if we know that most people in Africa are working in really demanding healthcare systems, and that's a burden that a single person can't really shoulder. So if we want to be able to take that forward, the entire team has to obviously take on that task, whatever it is. And I think the point that I wanted to make is that having individuals who are competent and putting them all together without having the team collectively competent, it can be a recipe for disaster, because as you mentioned, with beliefs and values, people are often pulling in different directions. The team, the whole group, has to be feeling and believing in the same thing in order for this to have any, remote degree of success.
So, Nicky, can I ask you, how does this relate to, the traditional hierarchical structures? For a team to be more successful, collective competency, for me, speaks to flattening our hierarchy.
Definitely. I think, as you mentioned somewhere in your book, we all kind of trained in those scenarios where you have someone who sometimes leads the team and is kind of barking the orders out at the rest of the team. And I think for collective competence completely reverses that. So we need to flatten the hierarchy completely, because I think that hierarchy does away with autonomy. It does away with the individual autonomy. It's you being told what to do and you hear whether you like it or not, and you kind of just have to do it. And chances are that that's where things fail. I think the whole point of collective competence is that we are all in it, we all believe the same thing, and we are all as important as one another, and we all as important to the success of whatever it is we're trying to achieve as the person next to us. Doesn't matter your rank, it doesn't matter your position, we all have an important role to play. So I think flattening out that hierarchy really is so important, because that hierarchy kind of kills the creativity, it kills the autonomy, it really is destructive for the team, I think.
Thanks, Nicky. I think that's probably a good place to bring Rupert in, because Rupert and I have been very successful at failure. We've tried to improve outcomes across Africa in the one trial which was known as ASOS2, which is described in the book as well. And Rupert has also been involved in nationwide NHS improvement projects, which unfortunately also haven't been as successful as we would have hoped. I think, Rupert, what has your experience or learning been, from these initial attempts of improving health for all?
Oh, well, thanks, Bruce. And first of all, thank you for getting me on the podcast. It's really lovely to chat about your amazing book. I think there's lots of interesting learning, and it's really interesting listening to Nicky's analysis and perspective, almost all of which I agree with. There's sort of one or two little bits I might sort of qualify, but I suspect they wouldn't actually necessarily, well, I hope wouldn't necessarily be completely contrary to what Nick has explained. But for me, there are a bunch of stuff, but the most important thing of all is complexity. Healthcare is complex. It's not a simple system. One hospital ward is not the same as the next one. One hospital is not the same as the next one. One patient, one surgeon, one anaesthetist, and so it goes on. But moreover, these things change with time, and they're all changing all around us all the time. And so whatever we're trying to do to improve that system needs to allow for the fact of this constant complex change. I may come to work and I'm full of beans and I'm feeling really great and really motivated, but I may be working with you today, Bruce, when perhaps you're not at your best. Maybe you've had some bad news at home. And, whatever we're doing on that day and whatever we're trying to change in the system around us relies on us as people. Effectively, healthcare are people. And anything that involves getting people to behave differently in a collective way is inevitably very complex. And the more you can understand people in the way that Nicky described, the more likely you are to leverage change. The bit where I'm not sure it completely aligns with Nicky, with what you've explained, is around leadership. Because if you take a healthcare system, you take a research study, you take any situation where you want to affect change, you need a leader. And whilst I totally agree that hierarchical leadership, where you have to do what I say because I'm the boss and you do everything the boss says, that's not a great form of leadership. People don't do their best because they have to, they do their best because they want to. So the best kind of leadership is what I would call soft power. That is, that people do things for me because they believe in what I'm trying to achieve, because they think what I am trying to do is important, and hopefully because they like me, although that's probably the least important of the three things. So that soft power means that people will do what I ask, not because they have to, not because it's their job, not because I can fire them, but because they believe in that mission. And usually in some kind of healthcare system, there's lots of options about how you cope with this complexity. There's lots of different ways of trying to solve the problem. And if you don't have a leader going, yes, I understand there are lots of different ways, but we're just going to choose this one. We're just going to do it this way today. And everyone sort of together understands that there are lots of choices, that they could suggest a different choice if they thought that was necessary. But ultimately, a decision needs to be made and we need to follow that leader. So if you completely eliminate the hierarchy, totally eliminate it, then you are reliant on everybody having a commonality of purpose. You're essentially relying on it being a simple system, not a complex one. And so what really for me it boils down to is, what does that leadership look like? So that would be the sort of question I'd ask Nicky, would be, what's that leadership look like? And how does that concept of leadership fit with what I agree, which is the negative implications of hierarchy for how the team performs and how they feel when they go home and the moral injury that they may experience at work?
So I think that's a great point. I think for me, it's, as you say, you have to have somebody leading. Otherwise, potentially you could have everyone running in various directions. I think for me, it's about the type of leadership. And that's the important thing. So if you have the dictatorial leader who's going to say it's my way or the highway, and I don't care what the team thinks, I think that's the hierarchy that we're talking about.
Yeah.
If you look at CPR, and how we do CPR, and you have your various role players, and you have someone doing defib and someone doing drugs and someone doing airway and someone being the team leader. For me, it's about the importance of the individual. So yes, the team leader is important, but to me, he's no more important than the person who is defibrillating someone who's in VF.
Yes.
So everyone has a role. It's about, okay, your role happens to be the team leader. Your role happens to be this. Your role happens to be that. But the team leader is part of the team, and he or she is going to take into account how everyone is feeling, how everyone is thinking, and collectively make decisions. So I think that's very different from the traditional type of leader that maybe we're used to and we're trying to move away from. So I just see it as one of the roles that somebody in the team is taking on, which hopefully makes sense.
Oh, no, totally. And that leader is no more important or less important than anybody else. As you say, it's a specialist role, but there are other key specialists within that team. I think that puts it really nicely. There's an interesting sort of conversation you can have about the traditional way. I'm a lot older than you, the way I was brought up, that you respected your elders and your betters in a certain way. They got treated differently because they were older.
Yeah.
But they're human beings, and younger people are human beings. And, should you treat a wealthy person or a poor person or an older person or a younger person or maybe a man or a woman, or how far do we want to go with labeling people as different and saying that they are entitled to different types of consideration and treatment? I think as soon as you start going down that slippery slope, you get into the kind of problems that you're talking about. And I think roles within healthcare, professional roles within work, are a good example of that. Everybody is entitled to the same amount of respect, because they could easily be the most junior person, but doing the most important job on that team on that day.
Absolutely.
So I think, this is a very important point. Like, a lot of what we're discussing is about allowing everyone to have a voice.
Mm-hmm.
And if you squash voices, the safety for the patient is compromised. And so I think Rupert used a good word, respect, respect for everyone in the team, allow them to speak up, listen, and value everyone's contributions. Do you think this concept could go further than health in Africa and improving surgical outcomes in Africa? And I know a lot of people who listen to the Earthcast podcast are obviously interested in Africa and in its environment. Nicky, do you think, how could one take this concept of collective competency and value-based leadership to a broader concept of looking after the planet?
For me, Bruce, thinking about it recently, it's definitely not a new concept. I think certainly in Africa, we've been doing it for a long time without even realizing it. I mean, if we look at Ubuntu and what it means in a community, when a child is being raised by a community because their parents are working far away from the rural village or wherever it is, everyone takes responsibility for the upbringing of this child. So everyone feels as important. The granny in 2 huts away has a role to play in the upbringing of this child. And I think if we're looking at it from the core family perspective, you can go out to teaching at schools, you can go as far as sports teams. And I think, recently you look at the Rugby World Cup and what South Africa was able to achieve and that kind of thing. I mean, that's collective competency at its best, where you're looking at how well a team can perform when they all perform together, and you have a leader who is not above or elevating himself above the others. He feels he is, has the same role to play, the importance of the same role to play with the others, and what you can do as a team when you have that kind of mindset. And I think, if we can kind of take that mindset, which clearly has been around already, and maybe we're not appreciating it, and we put it into places of importance like government, where we say, okay, from a governance point of view, people need to be responsible collectively for outcomes, whether it's looking at education, health, whatever it is, taking that collective competency approach, I think is really good and would be great. It does kind of undermine the hierarchy that is sometimes so steep in places like government. But I think we'd probably do a lot better if we had this kind of concept there where people think that their voices are as important and they can go out there and make greater changes.
Thank you. I actually think this is a good place to round up this podcast for a few reasons. The first is you introduced the concept of Ubuntu, and Ubuntu is discussed in this book and in this section about competency and leadership. And you also touched on, governments and approaching them. And that's later in the book, dealing with advocacy, and we will be discussing that in a subsequent podcast, the voice of the people and the responsibility of the government. So I think we shouldn't overreach today. I appreciate, the time of Nicky and Rupert. You guys are great colleagues. You've taught me a lot. It's been a privilege to be able just to spend 20 minutes chatting with you. Thank you.
Thanks, Bruce. Thanks, Nicky.
Thanks, Bruce. Thanks, Rupert.
What question you should have asked me? So I guess the question you should have asked me is, how does improvement in patient care in high-income countries like the UK differ from improvements in patient care in countries in Africa? The thing that people often say to me is that Africa is completely different. The context of hospitals, the nature of the way hospitals are in Africa is totally different. And there's no real overlap in learning or understanding between a high-income country health system and a low-income country health system. I mean, that first of all suggests there's nothing to learn in the UK from how you do things in Africa. I think that's the first really important point, because there's all sorts of things we can learn about how you deliver healthcare in Africa that we can learn to do things better in the UK and other high-income systems. But I think the more important point is that whilst the context in every hospital in Africa is different, there are teaching hospitals, there are regional hospitals, there are district hospitals, they have different types of services, different staff, some are rural, some are inner city, and so on. Really, there's only a few things that make hospitals different. It's just the combinations are infinite. But if you look at what makes a hospital different, it's things like leadership. Leadership's almost certainly the most important thing in terms of improving healthcare. Great compassionate leadership that leads to great followers who want to improve the health system that they work in and know how. The ability to work with patients in your community. Aspects of the built environment, which may be old and out of date, or it may be new and shiny, but not exactly fitting what you need. There may be other problems with the built environment, such as your electricity supply or your oxygen supply. There may be problems in how different professional groups interact, such as nurses and doctors, for example. There may be the pool of non-public funded medicine, so the lure of work in private sector hospitals. All of these things and more are the same in every country around the world. It's just the exact nature of them and the combination of how they function in individual hospitals is different. So I think the thing to really ponder from my point of view is, how does understanding how you leverage those different factors that determine great healthcare, how does that overlap across countries? And that means, how can we share the learning that we have in quality improvement in high-income country health systems with low-income country health systems? And how can that learning be reciprocated in the other direction?